Good morning, my colleagues. In our session, Head and Neck Code 5 seats. Inshallah, today we have a very long list of about 50 cases and about 25 candidates to be examined. Hopefully, we will cooperate with each other to finish as much as possible. Let's start with our first candidate. Are you ready?
Sir,
My
should I start? Yes,
yeah,
I'm ready.
80-year-old.
Okay,
Doctor, could you, I want to, from all candidates to request control as much as possible. This is very
okay, sir.
beneficial. To
Yes, sir, I'm
simulate,
asking for the control.
yeah. To simulate the examination atmosphere, please. 8 years old male patient presented with a 2-week history of nasal congestion and snoring at night.
Okay, sir. I'm provided with scout image of the CT neck and chest region, and it's a scanogram in which I can appreciate that there is a large soft tissue opacity which can be appreciated in the prevertebral region and along the base of the skull, and it's a large soft tissue opacification. I cannot appreciate any air fluid level inside it, and no gross bony erosion can be appreciated, and so next, I would like to see the correlate my findings with the cross-sectional study. Now I'm provided with a contrast enhanced scan
Scroll,
of.
doctor.
Yes, sir, I'm scrolling. Okay, I'm scrolling from. I'll first of all I'll go to the top and then start commenting. So the visualized section of the brain, they are unremarkable. And then as I scroll down, I can appreciate that there is a large heterogeneous soft tissue enhancing mass lesion is can be appreciated. This is predominantly centering in the region of the nasopharynx, and in the nasopharynx, I am unable to see the fossa of Rosen-Miller or eustachian tube space, and it is causing marked obliteration of the nasopharynx, and superiorly, anteriorly, it is causing obstruction of the bilateral nasal cavities as well. And then laterally, it is causing remodeling of the bilateral pterygoid bones, and also there is contralateral spread into the parapharyngeal space, also noted, and causing marked narrowing of the oropharynx as well. And okay, so I'll scroll down, and in the confinement of the mediastinal window, the visualized upper chest and apices are unremarkable, and the vessels, the jugular veins, and they are normally contrast opacifying. And it's a highly vascular lesion which is centered in the nasopharynx. I would ask about any history of nasal bleed. This is concerning for nasal angiofibroma. I would also like to correlate it with the coronal and axial imaging, and also look the bone window to look for any bony remodeling or bony erosions, and refer the patient to ENT surgeon and enter and IR for endovascular embolization of this lesion.
What is other differential diagnosis?
Uh, Sir, in an 80-year-old, uh, it could be tonsillitis with tonsillar abscesses and or some pharyngeal to pharyngeal abscess.
Okay, what else?
It is in a
What do you think abscess tonsillitis with abscess would you remodulate the bone like this and make this bony changes?
no, sir, very unlikely.
So what is your other differential? Angio juvenile angio tumor is a good diagnosis, but in this age group,
Mm.
what
Sir, it
else?
could be any sarcomatous lesion can be also
Excellent. Like
one of the differential.
mm,
Sir,
like
like
what?
soft tissue sarcoma
Okay,
or
let's go to
rhabdomyosarcoma.
doctor. Your voice little bit have some echo. Try to fix it problem, please.
Okay, sir. Okay, okay.
60-year-old male patient has left neck swelling. Go, go on.
Okay, sir. I am provided with the T2 axial images of a 62-year-old male patient who presented with neck swelling. And first of all, I'll scroll from top. The visualized section of the brain appears unremarkable, and the bilateral parotid glands are also unremarkable. Then I can appreciate that there is a large heterogeneous ultramuscular intensity lesion, which can be appreciated in the right half of the tongue and
Excellent.
also involving the base of the tongue as well. And then as I scroll, I can appreciate that there are well defined rounded nodules sit in the region of the neck, predominantly involving the level 2A. And
Yes,
I would like to review this on the post contrast images and diffusion restriction to look for any acute restricted diffusion enhancement in the tongue. And so this is likely a
1 minute,
case of
1 minute,
uh, I would-
1 minute. Leave the
okay,
mouse. Look here.
okay, sir.
Hmm.
So the time is over.
Okay.
Okay. Yeah. Let's conclude, Dr. Omer, please.
Okay, sir. So this is likely a case of CA carcinoma of the tongue with the necrotic
Yes.
lymphadenopathy involving the right cervical chain.
Excellent. What else? Something important to talk about, please.
So bony erosions,
Especially,
it is also causing
what
bony
else?
erosions. And
What else?
is it differential?
No, no. This is okay. Squamous cell carcinoma of the tongue. But
Yes, sir. Yes,
from coronal,
famous.
we must exclude something very important because it will help the surgeon to take the correct decision.
Sir,
See?
contralateral involvement and involvement of the posterior aspect of the tongue and
Okay, what
extension of
else?
the sleeve.
Leave the mouse. Leave the mouse. Look here.
Okay.
Look here. Hmm. Look here. What happened here?
Sir,
Hmm.
it is reaching
Yes.
till the larynx and also involving the epiglottis and uh,
Okay. You are not very far. Thank you, Dr. Omer, too much. This is a classic
thank you, sir.
case of. Thank you so much. Yani, you did very well. I appreciate your style. You are very confident. The most important notes from Dr. Omer's style, he takes the exam till the end. This is very important. And this is very crucial. Sometimes the finding in the side. See, this is a cavitating lymph nodes, bilateral cervical. Okay. So I'm thinking about squamous cell carcinoma. Here, the squamous cell carcinoma is very obvious, affecting the lung, the tongue. The first important, this first note for you, doctor, this is past the median raphe of the tongue. See, contralateral side. What's it's important? It will change the surgical decision from partial glossectomy to hemiglossectomy or total, whatever, but it
Okay, sir.
will change. Second point,
Okay, sir.
second point, there are a wide infiltration for the base of the mouth, the floor of the mouth, infiltration of the genoglossus, hyoglossus, whatever. Doctor, I didn't know how to differentiate between the different muscles. Okay, tell the examiner, doctor, there are significant extension to the floor of the mouth. Why? See, I think it is perforated the muscle and it came to the subcutaneous tissue. This is very critical. This is the lymph node. Why it is very critical? Because it will change completely the surgical procedure. Why? Because the floor of the mouth must be resected. Second, the floor of the mouth after irradiation, resection must be reconstructed. This is a one of the huge major surgical procedure. So when we are reporting in full details, especially critical details, the surgeon will get the correct decision from our. Thank you, doctor, so much. This is also a very nice case. Your diagnosis is very well, except here. See, the bone here, not erosion. I think there are more than erosion. See, in the corner, you didn't ask me to show the corona, so I will not give to you. There are very obvious destruction here. And I think if an MRI done, you may detect some intracranial or even some meningeal spread. This is very critical. This is will change the plan of treatment. Okay. This case of an aggressive nasopharyngeal and to the right side masticatory space, aggressive tumoral infiltrative lesion, destructive the bone. First, destructive the tragoid. This is not just scalping. This is, I think, this is destruction. Then skull base and most critical. Okay, and here there are some extension or the involvement of the foramina here. Doctor, I don't know to differentiate. I forget the foramina. Hey, tell the examiner there are a high possibility of skull base infiltration. Thank you so much if you tell the examiner like this. A differential diagnosis according to the age of patient, 8 years old. Number one is nasopharyngeal rhabdomyosarcoma. Nasopharyngeal rhabdomyosarcoma. Number two, juvenile angiofibroma. Okay. Next candidate.
Thank you, sir. Thank you very much.
Thank you, Dr. Umay. Next
Assalamu
candidate.
Assalamu
5-minute timing, please. Could you request the control?
Sir, I'm requesting 1 minute, please. I couldn't
You.
find that.
If you can find it. What's your name, doctor? To give
Dr. Sobia.
in the chat box, Dr. Sobia, or you change it to candidate?
No, sir, I'm trying.
Hmm.
Sir, could you please call for me today? Next time, inshallah, I'll try my best. Although I have.
No problem. No problem. Because my colleagues in the exam scenario, the examiner insists for you, you should scroll. Okay.
Sir, I found it. Sir, I found it.
Okay, very nice. Very fantastic. 55-year-old female patient presented with increasing left neck swelling.
Sure.
Go on.
Okay. I'm provided with the CT scan brain plane, CT scan with contrast.
Excellent.
So I'm looking from top to bottom,
Excellent.
and I can see no significant abnormality seen within the brain parenchyma. There is evidence of a large heterogeneously enhancing mass lesion in the left side of the neck that has heterogeneous enhancement, and it is anteriorly displacing the carotid space anteromedially. Posteriorly, it is extending up to the. So posteriorly is extending up to the cervical region. However, no infiltration of the sternocleidomastoid muscle is seen. So the mass has sharp lobulated margins. No definite vascular invasion is seen. However, it is compressing the vessels, but no definite vascular invasion is seen. The pre and paravertebral spaces are intact. I would like to see the coronal images as well, sir, to see the exact extension of this lesion.
1 minute. Yes. Yeah, go on.
Yes, sir.
Yes, go on.
Sir, I cannot. It's not like.
Scrollable.
Yes, now, sir, I can see. So similar findings: heterogeneously enhancing, well-defined mass lesion in the left half of the neck region. That is displacing the vessels. So no definite. So I would like to see the bone window if there is any bony erosion.
No bone window.
So overall.
What's your diagnosis, please?
This is likely a mass lesion. It could be schwannoma or
what else?
So this could be a large necrotic lymph node,
Are you
other
sure?
differential includes, sir, and
Are you sure? Necrotic lymph
less
node?
likely to be a lymph node, less likely to be a lymph node. So this is likely a mass
Yes.
lesion.
Yes.
Likely, sir,
Schwannoma.
schwannoma, a
El
neurogenic tumor
Excellent.
or paraganglioma, sir, in this region.
Excellent. Mm-hmm.
Uh, uh, um, so rest of the bin parenchyma appears unremarkable. I cannot see any necrotic lymph nodes or
You wanted
any
to, do you want to exclude any associated signs?
Yes, sir. Displaying sign of the carotid vessels.
Okay.
Sir, yes, sir. So there is. Sir, let me
1
see
minute.
the exit. Yes,
1
sir. There
minute.
is displaying of the vessels. There is displaying of the vessels.
Look again, please. Look again.
Yes, sir. There is displaying of the carotid
No
vessels.
spelling. No
Not
spelling.
sign. Yes.
Mm-hmm.
Okay.
No spelling. What else?
Uh, Sir, rest of the fat planes are clear on the right side. There is no pre or paravertebral lesion seen. Uh,
Okay.
the oropharynx and the nasopharynx appear unremarkable.
Thank
So
you.
I would like to
40-year.
advise, yes.
Okay. 40-year-old male patient presented with chronic high pitch left pulsatile tinnitus associated with pre-on auscultation of the left pre-auricular region. Go on.
Yes, sir. Sir, I am provided with the MRI,
Yes.
middle sections, clear sequence. So the brain parenchyma appears to be unremarkable. No definite focal lesion is seen. Yes, sir, I'm looking for the lesion on the left side. Yes, sir, here I can see. So could you please scroll for me? Actually, it is jumping, so I cannot focus. So there is a soft tissue intensity mass lesion in the region of the jugular foramen on the left side.
Excellent.
Sir, the lesion has no other differential intensity within it. I would like to see the contrast and DWI of this MRI for further evaluation, as well as I would like to see the angio if available.
This is the angio.
Yes, sir.
MRA
Okay.
or MRV?
MRA, sir.
Time is
Excellent.
over.
Okay, thank
Okay,
you.
so
Tell me your
there is no
diagnosis.
significant enhancement. So there's no significant enhancement of this lesion. So it's less likely to be a paraganglioma. So this could be schwannoma or any other.
Wait. Doctor, wait. This is no contrast here. This is MRA tough technique.
Okay.
Okay? And the pathology is in this slice. Tell me, this is the arteries. What is this?
Sir, I can see.
What is
So there
this?
is. So this is transverse sinus.
Okay,
I
what
can see
happened?
there is a hyper. So there is a hyperintensity within this area, likely presenting
Excellent.
thrombus within
No.
the transverse sinus.
No. See, we are acquisiting an arterial phase. Then during this, we saw the transverse sinus. But you tell me what happened? Why the transverse sinus is seen during the arterial phase or during MRA?
So this could be due to fistulous communication or
What an
any
excellent.
thrombus.
Thank you. Doctor, it is very difficult case. This one. This is the most difficult case of today, 50 cases. Thank you, doctor, so much. You picked up at the beginning, but you hesitate later on. See, my colleagues, this is one of the scenarios that face most of us is inside the exam. You find something abnormal here in the beginning. Very good. Your startup were amazing. Very subtle, but you pick up. Better to tell there are signal abnormality rather than a mass lesion. Why? Because open the window of the differential diagnosis. Why? Because after I show you this one, this is not a mass lesion. There are some abnormality in the vessels of the brain, whatever veins, artery. Okay, this is arterial or this is axial MRA. What happened here? This is the arteries. Okay, and then what happened here? I can see signal abnormality or flow in the left transverse sinus. So in my brain, I must discuss. It should be some abnormal connection between the arterial system and the left transverse and sigmoid sinus. So it is a dural arteriovenous fistula of the left transverse sigmoid sinus. Okay, very good. In this case before, this case is classic case. Okay, but where is the trick here? This is looks like a brain CT. Okay, if you didn't exam or see all cuts till the end, you will lose it. There are heterogeneously enhanced method. This mass displacing all the vessels almost anterior. So it is not a carotid body tumor. Carotid body tumor will separate or splaying internal from external carotid. This is very characteristic. So let's think about other differential diagnosis like vagal schwannoma or sympathetic exchange schwannoma. Okay, I didn't want you to go in more details uh, like vagal schwannoma lies between internal carotid artery and the internal jugular vein, and it tended to separate them, and it is placing internal carotid artery. I think this is so sophisticated. If you know it, good. But I think you need to know at least this is not carotid body tumor. Okay. Second point, this is almost schwannoma. I ask you what science you wanted to exclude. If I told you what syndrome, خلاص, I like this, I give you the answer. This is schwannoma, so we must exclude neurofibromatosis. Neurofibromatosis. We should look here, look at the orbit, optic nerve, either schwannoma, glioma, also at hypothalamus, here, and intraventricular or other sites of meningioma, ependymoma. Like this, if you tell the examiner like this, he will give you the highest mark. Thank you, doctor, so much. Next candidate. Candidate is ready.
Yes.
Can you request a control or should I scroll for you?
Yes, I will request the control.
90-year-old.
Request it.
Welcome. 90-year-old male patient underwent CTA of a head and neck for follow-up after thrombectomy. He had no auditory symptoms. Go on, doctor.
Okay, I have been provided with okay, I have been provided with a CT, axial CT images, bone window of an head and neck region. I'm scrolling from top to bottom.
Okay.
I can see there is evidence of soft tissue swelling is noted around the
Don't worry.
sphenoid ridge.
Don't worry about it. Look at the skull base, please.
Okay. I can see there is a widening and widening of the internal auditory meatus is noted.
Mhm.
It is expanded and there is some erosion is also noted around it. The mastoid hair cells appears normal in this region.
See, this is positional because the patient is not well centralized. But look in this area, the pathology, yes, in the right side, this area. What else?
There is soft tissue also projected into the internal auditory canal.
Brilliant. You are brilliant. Go on.
This can be a aberrant internal carotid artery.
Yes. What will you do next?
I will convey my finding to the referring physician, and uh, maybe CT angio can be done for further confirmation. Before
Okay.
that, I would like to see the CT images, soft tissue window, brain images,
Leave the
and
mouse.
also CT angio.
Leave the mouse, please.
Okay.
Okay. Oh,
Okay, I have been provided with the axial CT images post contrast CT angio. Here I can see that the internal carotid artery also
excellent.
projected into the internal auditory canal. Uh,
Yes. What's
and
your differential diagnosis? Give
in
me
this,
differential.
one is the aberrant internal carotid artery.
Yes.
Other other is some vascular tumor, but least likely as it is appears to be a vessels.
Excellent.
And
Excellent. Yes. Do you know the pathology, underlying pathology of this abnormality?
there may be abnormal development in congenital, but I'm not sure exactly.
More than excellent. Next case. 30-year-old female patient, left-sided conductive hearing loss and facial nerve palsy. Here you are. Go on.
Um, shall I request for remote control? Okay, I have remote
No
control.
request. No request. Go on.
I have been provided with axial T2 MRI images of a brain
Yes.
of a patient who is presented with a complaint of left-sided conductive hearing loss. Here I can see there is an abnormal signal intensity lesion
Excellent.
noted in the left mastoid air cell,
Not mastoid. This is a
middle ear
cutting.
cavity.
Yes, not middle, but يعني this is within the left ear. Okay, no problem. Go on.
Um, it is showing a ISO2 hyperintense signal on the T1 weighted images. And
Yes.
the internal auditory canal appears normal, the inner ear cochlea appears normal. I
Yes.
would like to see the T1 weighted images or the post contrast images to
Mhm.
further confirm it.
This is post contrast. Yeah, give me your differential diagnosis.
It is appears vascular. This can be a glomeus tumor uh,
Okay. What else?
or jugular descents can be occur, but it does not look like a jugular descent. Other
Yes.
cholestotoma, but they usually cause more
Are you
erosion.
sure? Are you sure it could be cholesteatoma after this avid homogeneous enhancement? This
No,
is
no.
by the way, like you said, this is inside the middle ear. So give me the last differential diagnosis, please.
Last differential in the middle ear automastitis, but again less likely.
Mastocytis will show this is avid enhancement. Look
No.
here. Look here. Enhancing mass lesion within the middle ear. What it could be?
One is a glomeus tumor. One is
Okay. Time
I can't remember.
finish.
Okay.
Time finish or not? Doctors who give us 6 minute time up. Nobody. I think time finish.
Yes,
Thank you,
sir.
Dr. Som.
Yes, sir.
Finish or
Time
still?
finished.
Thank you so much.
No,
Thank you, Dr.
finish,
So.
finish, time finished.
Thank you so much. Thank you, Doctor, so much. You are really brilliant, especially in first case. Let's see this case. See here, this is a lesion here, and this is the cochlea, okay? And this is the cochlea. This is the seventh and the eighth cranial nerve, and this is lesion, solid mass lesion within the middle ear cavity, okay? Then you ask for contrast, it is avid enhancement. You said very well when you give me a good logic differential diagnosis, including number one, glomus. Number two, where is schwannoma? Facial nerve schwannoma. It is very important here. Very important. Number three, you told it may be high riding or dehiscent jugular canal. No, not possible. You can see a very clear separation. This is the sigmoid sinus okay? And the jugular here, it's totally separated. So don't include differential analogic differential diagnosis. This case is a classic case of left-sided facial nerve schwannoma. The most common, as you know, the facial nerve has 6 or 5 parts. The most common part that originate from it schwannoma is the geniculate ganglion. The geniculate ganglion. Okay, very nice, doctor. You did very, very well in this case. This case, one of the difficult case here. You did very well. You told me, Doctor, oh, I see here some soft tissue abnormality. More than excellent. More than excellent. Let let's give me the post contrast or the angio. I see here. This is the internal carotid, right internal carotid. Oh, the internal carotid. There are absence of the bony part here. The bony part here is not seen, and the internal carotid, the lateral wall of the right carotid canal is dehiscent. So the internal carotid is projecting within the middle ear cavity, adjacent to the ossicular chains. So this is parent internal carotid artery, parent parent internal carotid artery in the middle ear. Thank you so much. By the way, I ask you the last question to give you the full mark. It occurred due to developmental changes in the embryonic vessels. Okay, thank you so much, doctor. You did very well.
Thank you, sir.
Next candidate. Next candidate.
Yes, sir.
Welcome.
Thank you, sir.
Could you request the
Yes, sir,
control?
I'm requesting.
Today, really, I consider today one of the fantastic prova scenario for Viva. Why? Why? Because of requesting of control. This is very important. Second, we have a multiplicity of different cases, of different scenarios. Third, the stress, the good number of participants now simulate the exam in its stress, give some stress on the candidate, and this is very good. Don't expect this is bad for you. No. This is train you for the stress of the Viva exam. 35 years. Start 6 minutes, please, our doctor.
Yes.
6 minutes time. Thank you. 35-year-old male patient with acute onset of left facial soft tissue swelling and pain. Yalla, go on.
We did with axial titubated MR in the region of neck. I can see that there is signal abnormality in the region of left parotid gland. It is in the deep lobe of the parotid. I can see central hypointensity with surrounding hyperintensity.
Excellent.
And I would like to see sir post-contrast images to see whether it is an abscess, because this is an acute process. I can see internal septations. So can
If
I
I
see
told you,
contrast?
if I told you what sequence you want to see before
Sir, DWI.
post-contrast,
Sir, DWI.
this
Diffusion.
is DWI. Yes, go on.
Sir, in diffusion, it is showing restriction.
Yes.
It is showing central restriction. I would like to confirm it on ADC. And there is a
ADC.
Yeah.
Go
sir,
on.
on
Mouse with
scrolling
you.
is a little bit difficult. Scrolling is a difficult. Okay. And it is showing yes, hypointensity on ADC. So this is a restricting lesion. So likely a parotid abscess.
Excellent.
I would like to see if there is any stone obstructing the parotid, causing parotid abscess.
Which sequence you want to fix it
SWI,
soon?
sir, SWI.
Let me see if we have. No SWI, I think. This is only this one.
Sir, I cannot find any stone. The scrolling is very much jumping. Can you scroll from?
This is a post contrast. What's your
Yes,
diagnosis?
post-contrast ring enhancement. So it is a parotid abscess, and I would urgently convey my finding to the referring clinician for the drainage of the abscess and for
Thank
the
you so much.
an exacerbating factor.
Thank you so much. 40-year-old male patient complaining of neck pain, dysphagia, podniphagia, and body weight loss.
I'm presented with a scanogram image of lateral cervical
Yes,
spine, in
yes,
which I can see gross soft tissue thickening in the prevertebral region and the upper
yes,
cervical vertebra, which is causing narrowing of the oropharynx and the nasopharynx. I would
yes,
like to see this in the contrast enhanced CT of the neck for further elaboration of the abnormality. And I would also I like to ask if there is any history of fever. I can see hypodense collection in the retropharyngeal region on
yes.
which is which is extending to both sides, and
Yalla,
it
scroll
is
for yourself. See, this case, your scrolling is crucial. Please scroll.
okay. The brain appears normal, and the nasopharynx
Yes,
is wide open, but the oropharynx is being narrowed by this collection. And
yes.
almost complete obliteration of the airways, which is an emergency and need to be urgently managed
Then
by airway
excellent.
securing.
Yes,
Uh,
yes,
uh, as I scroll down, this collection is extending down into the larynx
yes.
and into the superior mediastinum. So it has extended into the danger space, and I can see that there is collapse and consolidation of the lung, and maybe the extension of the infection into the lung parenchyma also.
What's your
Um,
differential?
so my differential is a retropharyngeal abscess extending into the danger space and
Look
superior
here.
mediastinum.
Give me
Uh,
the type of the
sir,
retropharyngeal. Mm,
Sir, this can be due to the vertebral disc osteomyelitis, which is extending into the retropharyngeal space, because I can see erosion of the subtle erosion of the second vertebral body as well.
What type of pathogenesis here?
Sir, it can be tuberculosis,
Yes.
which has eroded into the then retropharyngeal space. Tuberculous vertebral osteomyelitis with extension in
What
the
will you notice?
retrovertebral space and danger space. I would
What will you
urgently convey
notice?
my I would urgently
Yes.
convey my findings to the referring clinician for the securation of the airway first, and then to isolate the patient to
Excellent.
screening for TB and for family screening, and notify this case to the infectious control authorities, and further start the treatment of TB and drainage of this abscess as well.
What type of transmission of this bony pathology? If this TB, how could it reach the bone?
Sir, I cannot understand the question. Can you repeat?
You told me this is almost a tuberculous retropharyngeal collection or abscess.
Yes,
Okay.
sir. Mm-hmm.
What is the mode of transmission of the osseous TB?
Sir, hematogenous.
Excellent. More than excellent, doctor. Thank you so
So
much.
time
You
is
did
over.
very well. You did very well. This is a tuberculous retropharyngeal abscess with cervical pod disease. You forget to tell me this is a pod disease. Why?
Both.
There are an erosion here for C2. Okay.
Yes.
Second point, you did very well when you talk about during your description about saving the patient life by securing the airway. Second, you talk about the prevention of infection by isolation the patient. Thank you so much. You did this case very, very well. TB cases is very, very common during examination, either in long cases, in Viva, even in short cases. Expect to be my colleagues very common. This case is an easy case. But why I insert this case? Because it is easy and maybe missed from most of us. There are abnormality here in the parotid. But doctor, my advice to you, you start to tell me that your finding before you see all the examination. Okay?
Mm-hmm.
Take your time.
Mm-hmm.
10 seconds is more than enough. Take a look. Okay? Because
Okay, sir.
sometimes the major pathology is not this. It may be cyst. And there are here something, okay, or there are in the
Mm-hmm.
brain's major pathology. So take your time first. Take
Yes,
your
sir.
time
Thank
first,
you.
and then start to talk. Okay?
Okay, sir.
This is
So, was
parotid.
there any factor causing this abscess? I couldn't identify the
Give
factor
me my
causing this
chance.
abscess.
Give me my chance. Please. There are somebody who are using his my colleagues. Please. Who did this one? Anyway, let's finish this case. Don't ask for post contrast before conventional MRI sequence. You request post contrast before diffusion. Anyway, diffusion confirming this is restriction. Okay, but I wanted to tell you something very important. In any infectious case, look at the surrounding fat plane because sometimes the examiner wanted to make it difficult. So what he will do, he will give you something like T1, T2. Okay, you see here some abnormality only, and in T2 or in STER, this is the abnormality. If the lesion is like this ill-defined, as ill-defined signal abnormality, think more in an infectious disease. See here, there are signal abnormality affecting the parotid
Mm.
and the parotid gland and the surrounding tissue. Oh, it may be tumor. Okay, you are right, but look again. The edema is is ill-defined because some examiners are tough and they will not give you fusion. They will not give you maybe a contrast. So you should keep some keys in your brain. This is ill-defined. And the second, I can see here the anatomy is still little bit preserved. So it looks like non-tumoral. At least you build up an idea about the nature of your pathology. Thank you so much, doctor. This is a left parotid abscess. يعني the pathology or the etiology is not known. Please, my colleagues, all of us, mute yourself, close your cameras, please. 1 second. Next candidate, are you ready?
Yes, sir. Assalamu alaikum.
Salam. Okay. 6 minute timing, please. I will stop share and reshare again to read this. Yeah. This group really contained fantastic candidates. Really, most of you are well prepared and study hard. Your performance of most of you are amazing. Really, I think most of John candidate will pass easily. Start. Could you ask control, please?
Mm.
3 months baby male. Her
I
mother
requested.
complaining of neck swelling. Go on.
Okay. This is a plain film frontal chest and abdominal radiograph of a 3-month-old child presented with neck
Mhm.
swelling. I can
Yes.
appreciate a large soft tissue swelling around the right side of the neck.
Mm.
I cannot appreciate any septations, any calcifications within this large soft tissue uh, lesion.
Mhm.
And I'm closely looking at the cervical spine. On this view, at least I cannot appreciate any obvious erosion or destruction. If possible, I would like to view any other view if available to
Yes.
further delineate the exact location and its communication.
Yes.
Okay, this is a post contrast CT.
Yes.
I'm trying. Okay, post contrast CT neck chest axial
Mhm.
sections. The large soft tissue lesion, which
Mhm.
was previously demonstrated on the plain film, it appears hypodense on this post-contrast CT and
Mhm.
is not showing any enhancement. It is
Yes.
extending along the right lateral chest wall.
Mm-hmm.
Um, okay, insinuating into the fat planes and the encroaching up to the carotid vessels,
Yes.
anteriorly, posteriorly about the muscles on the back,
Mm-hmm.
and no septations, no enhancing soft tissue mass is seen. I
Excellent.
can also appreciate a large soft tissue in the anterior
Don't
mediastinum.
worry. Don't worry about it. Don't worry.
Okay,
Normal variant. Baby is 3 months.
okay,
What else?
okay. Can I have other window?
No other window.
Okay.
What's your
Okay,
differential
so,
diagnosis?
so to conclude on this provider film, I think my first differential would be cystic hygroma or lymphangioma in this 3-month-old child.
Excellent.
For this, I would, as these have association with the Turner syndrome, chromosomal abnormalities,
More
so I
than
would suggest
excellent.
to review any other findings associated, and would immediately inform our findings to the clinical team. And I think this would also be appreciated maybe in the obstetrical scan, which was
What's
done
your
antenatal.
differential? What other differential
And
diagnosis?
um, cystic hygromas or lymphangioma have different types, and I think they're depending on their extent. They can also
What's
involve the neck.
other
Yes.
than cystic hygroma in the neck region? Large cystic lesion like this. Other than cystic hygroma, what's your differential diagnosis?
Um, less likely, but branchial cleft cysts,
Okay.
they're not so
What?
much large. I haven't seen at least.
Mm-hmm. What else?
Uh, and off midline,
Not midline.
I think
This is lateral.
off, it's off
Don't
off
worry.
midline. Yes. Okay.
Don't worry. 20-year-old male patient, 2 months of intermittent left facial pressure, headache, and worsening left nasal obstruction. يلا. Sorry. Go on.
Okay. This is a CT head and face
Yes.
coronal view. This is bone
Yes.
window.
Yes.
Um, I can sorry. I can appreciate a large soft tissue mass.
Yes.
Just a minute.
Mm.
The scrolling is okay. So large soft tissue mass that is occupying the left maxillary sinus, extending into
Yes.
the ipsilateral nasal cavity. With
Mm-hmm.
I can appreciate significant bone erosion and destruction involving the medial wall of the maxillary sinus.
Excellent.
Superior and lateral walls also show erosion.
Excellent.
I can
Mm.
also appreciate intraorbital extension on the left side with the erosion of the lamina papyracea. I also suspect
Okay.
the cribriform plate in erosion as well. And
What's your differential diagnosis?
this is an aggressive lesion.
तो मैंने इसको
Uh,
मुझे भी एक गिलास पानी देना अली बेटा
uh,
तुम्हारा कप में
aggressive.
दूध डाल दिए कॉफी भी साथ
1
है
minute.
उधर ही पड़ी हुई जाओ
1
बोतल नहीं
minute.
वो
This
कर
is
1
लेना
minute.
aggressive lesion. This is with significant bone erosion and destruction. Um,
Mm-hmm.
Age is 20 years. In this young patient, I think
Yes.
I would keep infection as my first differential with second possibility of a malignant transformation.
What? This is an
On the
MRI. Mm?
okay, this is MR post contrast fat set.
Yes.
This is the mass is showing significant contrast enhancement with central
Yes.
non-enhancing areas and with the intraorbital and intracranial extension.
Okay.
So I think malignant lesion would be
Give
at
me
the
differential
top.
in this region.
This could be squamous cell carcinoma
What else?
of the
The patient is
sinonasal.
still young. Patient is young. What else?
In young patients, I think soft tissue rhabdomyosarcoma
More than excellent. What else? If
and
infection, what type of infection?
infections, osteomyelitis can be
Mm-hmm.
but it has a large soft tissue component.
Mm-hmm.
Mm,
Okay.
Or
Thank you, doctor,
spinal
so
side.
much. What will you do next? Tell me the
So
management.
time is over.
Oh,
Thank you, doctor.
okay.
Tell me the
This is an
management.
yeah,
Hmm.
this is an aggressive process and need immediate neurosurgical and ENT consultation, MDT discussion regarding its surgical planning and chemo if
Thank you, doctor,
required.
so much. You did very well. Take some notes for you. See, here you find from the first 10 seconds, this is aggressive destructive lesion. Okay? And you describe the extension. Don't take more time in more description. The examiner understand that you detect the aggressive nature. Either you give the next step, doctor, okay, I see there are an orbital extension and there are destruction here of the cribriform plate. Please, doctor, could you show me the post contrast? This is a post contrast. You saw it. Okay. Don't describe again. Don't describe again what you described in the non-contrast. Okay. Oh, doctor, there are this infiltration, and I have a doubt of brain intracranial extension. My next step is MRI. Like this, my doctors, you will get the highest mark. Okay, the doctor will show, for example, this stair. For example, okay, he will show you like this. And you are in a big doubt, doctor, I'm in a big doubt of intracranial extension. Could you show me post contrast or diffusion, whatever available? He will show you. If he didn't have, okay, you did your best and ask for your maximum, and the examiner will be happy. Oh, okay, there are really here. See here. I think this is meningeal involvement here. This is intracranial extension, my colleagues. Okay, it is like this should be our style in the exam. You did very well. This is nasal rhabdomyosarcoma. The best thing you did, you mentioned rhabdomyosarcoma before squamous cell carcinoma. Why? Because the patient is 20-year-old. So it is very critical, my colleagues, to concentrate in the history. Because when the examiner gives you a history, he means something. He wants from you a logic-related differential. Okay? Other differential may be invasive sinusitis, invasive fungal sinusitis. What is against, doctor, what is against sinusitis here, invasive
So high
sinusitis?
density. It should be high density on CT.
Okay, what else? Here in MRI, what is against?
It should be low signal and
In which sequence? Correct.
T2,
Invasive
T1,
fungal,
T2, they are
yeah.
low.
Okay, in T2 it should be low. Why? Due to
Yes,
the heavy metal. In
yes,
T1
sir.
it should be high. Okay?
Okay,
In T1
right.
it should be high. In T1 here, this is looks like soft tissue. Soft tissue. And by conventional, see, we can lose the case in the exam from conventional if we didn't know our basics. In this, fungal sinusitis should have some sort of high T1 signal and some sort of low T2. Very critical. I know that most of you know this criteria, but I wanted to reassure due to the stress exam situation, most of us forget many basics. Second and the last is very avid contrast uptake. See, very the avid heterogeneous contrast uptake. So we are dealing with a mass, not just a mucosal thickening of invasive sinusitis. Thank you, doctor, so much. You did very well. Okay. First case, this is classic cystic hygroma from the age, from the size, from the this is a cystic collection. The tricky part here, the differential. I'm waiting from you to tell me, doctor, it could be meningeocell, cervical meningeocell, or large septal encephalocell, or cystic teratoma, but there are no calcification or fatty component. This is the thymus, my colleagues. Please, in younger age, under 2 years, especially the thymus must be huge. Don't talk about it, please. Even in X-ray, we should later on do one pediatric session, and I will explain especially about the thymus because it is confusing. Thank you so much. Next candidate, are you ready?
Yes, sir, I'm ready.
Welcome. Would you request control?
Yes, sir.
55-year-old female patient with nasal
Sir, I
obstruction
have requested.
persistent
I have
for 10 years. Okay, I approved. Persistent for 10 years. Go on.
okay. So I am looking at CT scan images.
Yes,
Sir, I'm unable to scroll. No, I think it's moving now.
yes, go
Yes.
on.
So I am provided
Yes,
with CT scan images, bone window. I could
yes,
appreciate. Uh, I could appreciate that the frontal sinuses are well irritated. And now I'm looking at the maxillary sinuses. I could appreciate the maxillary sinus is also clear, but in the ethmoid sinuses, I could appreciate and um ill-defined mass originating from the left, right inferior nasal turbinate, extending
okay,
in right
okay.
ethmoid and maxillary, so in extending into the right ethmoid sinuses
Leave
and
the mouse. Leave the mouse 1 minute. 1 second, please.
okay.
Mhm.
On the
Go on.
coronal images, I could appreciate that there is a high density mass with central low density,
Okay,
middle and superior nasal turbinate. I could not appreciate any extension into the maxillary sinus. The orbital walls seem clear. So can you show me the ethmoidal sinuses?
okay. Is this mass?
Sorry,
Is this mass from the first look?
I'm
This
unable to hear
mass?
you.
Is this a
Yeah,
mass?
sir, I'm thinking of, as the fat planes are clear, I'm thinking of, and I could not see any obvious bone destruction. I'm thinking of
Yes,
some
yes. You are very near.
benign
This is
masses.
see. This is benign mass. This is a bony lesion, but this
Yes.
is something other than a bony, yani a bony mass. What happened here
Sir,
for
it
the
could
bone?
be bone expansion of the
Yes, excellent.
frontal bone,
Bone
and I could
expansion.
think,
Hmm,
yes.
excellent.
So
Yes,
I'm thinking of fibrous dysplasia
excellent. Bone
or
expansion plus what is the
ground
typical
glass matrix involved.
very
Yes.
typical. Excellent. What will you do next, or what will you do you want
I
from
would,
this exam?
sir, I would like to review the rest of the bony skeleton
Why?
to see any polyostotic involvement and rest of the brain as well. I could appreciate another calcified lesion involving the left
Okay.
parietal
If
bone.
if this patient has polyostotic fibrous dysplasia, leave the mouse.
Yes,
What's
yes.
your what is the name of associated syndromes?
Peculiar Bright syndrome with precocious puberty, and if there are soft tissue
Excellent.
myxomas, then the Mesa-Bird syndrome.
Thank you, doctor.
Peculiar,
60-year-old Macon Albright.
okay,
Okay. Thank you.
yes.
60-year-old male patient presented with painless swelling of the left upper cervical region. Go on.
Sorry, can you scroll up for me, please?
Yes.
Okay, I could appreciate abnormal density mass located in the left carotid sheath with few internal low vessels. So can you show me please the T2 sequence, please? The mass is significantly well defined and is causing splaying of ICA and ECA and is
Awesome.
bright on
Excellent.
T2. Can I see the
Okay.
post contrast sequences? I could appreciate significant post contrast enhancement within this mass and
So
considering the
differential.
imaging appearances. I'm thinking of carotid body tumor, paraganglioma, and other less likely differentials would include neurofibroma and schwannoma. However, they are considering avid enhancement. First is carotid body tumor. I would like to inform my findings to the referring physician and would like to do an octreotide scan or
Why?
a MIPG scan because the carotid body tumors will show the uptake. And we can also do
Okay,
the
he will see,
PETs.
see,
They are
he
most
will share the uptake, but what is the primary cause that you will do
uh,
octreotide
to
scan?
see any other in the abdomen and pelvis to see any other areas of uptake
What
to see
other syndromes associated with carotid body tumor?
syndromes
Do you know
associated.
any syndrome?
No, couldn't remember any.
No problem, don't worry. Right. What is the name of this sign?
So time is over.
It's salt and pepper.
Thank you. Thank you so much, doctor. You did very well. At least when we describe, we should from our your يعني, spontaneously tell doctor and Tito this is salt and pepper appearance. Beside the spelling, خلاص, like this, any examiner wanted to listen the common buzzword or the associated buzzword when you describe splaying and salt and water. Sorry, salt and pepper appearance. Okay, this salt and pepper appearance is due to punctate region of hemorrhage or slow flow. This is the salt. Okay, this is the salt. This is the white, the white, the high signal, and flow voids. This is the pepper. Okay. Second, I asked you very some little bit difficult question. Why you do octreotide scan? Because 10% of the carotid body is a familial bilateral. Sorry. 10% of the carotid body is bilateral and familial, and it may be multicentric or associated by other syndromes like MEN type 2, either A or B, or other phacomatosis like tuberous sclerosis, neurofibromatosis 1, von Hippel 2. Doctor, this is too much. No problem. Keep in your mind one or two of this knowledge. Why? To enrich your answer. Okay. In FRCR, we collect each half mark. Some of my colleagues just passed and just failed because of one half mark. Okay, this is our war. This is our fighting against, not against, to pass. So we must collect as much as possible. This case is a very classic but atypical. Why? Why? Most of us face the fibrous dysplasia in long bones, multistotic. See here, this is a little bit tricky. Especially, I start with axial. Axial. This is an expansion with ground glass appearance. In your mind, translate it into fibrous dysplasia. And later on, if you want to describe me, there are some obstruction of the right osteomulator complex and the nasal cavity. This is very good. But at least first, you should give me the proper answer. Fibrous dysplasia. Next candidate, please prepare yourself. Be ready. Fibrous dysplasia, my colleague, by the way, is due to abnormal formation of the bone. Why? It is a congenital or a genetic disease characterized by formation of non-organized woven bone. Woven bone. Yeah, what mean by woven bone? Abnormal immature bone. Finally, yeah, loss of the normal compact cortex and the medullary architecture result in this abnormality. Why fibrous dysplasia looks like ground glass appearance? Who knows the answer? This is very simple but very important question. Why? Anyone knows the answer? Open the mic, please. This is very good question. Why fibrous dysplasia is of a ground glass appearance? Anyone know?
Because the bone gets displaced by collagen formation.
Not collagen. Huh? What else?
Fibroblast,
What else? This is an osseous matrix, my colleagues. I think you mean you wanted to say that this is an osseous matrix. Let's revise. When we are dealing with a chondroid matrix, there are arches and rings of calcification. When we are dealing with osseous matrix, there are ground glass. Okay. Next candidate.
Yes, sir. Assalamu alaikum, sir.
عليكم السلام. I will check. Yeah. Let's start. This is fibrocirrhosis. We finish it. We finish this one or not? We finish this case?
Yes, sir. It's carotid body.
Yeah. Okay, let's start here. Okay. Yalla. 50-year-old female patient, swelling, pain, proptosis, decrease of vision.
Yes, sir.
Request the control, please.
Sir, you can please kindly scroll for me as I don't have the setup.
Okay, no problem.
So, sir, these are due to rigid axial views of an identification. So, I'm observing the brain window and I so there's my fixed normality in visualized curve of the brain. Sir, with the paranasal sinuses and the nasal sinus appears to be fine, and the brainstem also appears to be normal. Sir,
Yes, doctor,
in a
see, your voice is little bit unclear.
yes, some okay, sir. So there's a abnormal signal intensity areas identified along the retroorbital region on the right side. It is intracoronal and intracoronal T2 hyperintense area identified, which is seen to causing proptosis of the right lobe. It is intracoronal, but it's retrobulbar area, and it is also causing stretch the optic nerve, but no definite infiltration in T2 weighted image. I can't see here, but and posterior sclera also to be intact, and it is within the retrobulbar region, and it is causing mild expansion and pressure effect over the rectus muscle, interconal muscle. So on basis of this, I want to visualize on other images on T1 weighted as well as post contrast images.
Yes. Post
Yes,
contrast.
sir. Yes, sir, post contrast.
This is post contrast.
Okay, sir. So on post contrast images, um, uh, so there is no such there is a redemonstration of this lesion, but there is no enhancement or subtle enhancement is there in this retrobulbar abnormal signal intensity this area.
What's your diagnosis, please? Differential diagnosis. Give me differential diagnosis, please.
My differential will be so concerning age. First, I thought it's a hemangioma, but it shows some early enhancement in hemangioma.
What
The
else?
second difference,
What else?
lymphangioma,
Mm-hmm.
and third lymphangioma, and third one max would can be there, but there's no enhancement in this area.
Yes. See, doctor, your voice, I can't characterize most of your words. Please,
Okay.
yani, right?
So my yes, yes, yes. Differential first difference will be lymphangioma, and
Yes.
second I was thinking about hemangioma, but in hemangioma there must be there's enhancement like we should see dynamic studies in which there is early enhancement and then fill in, but there's no such enhancement in this case.
Okay.
Okay,
So your final diagnosis is?
so I'm thinking about lymphangioma.
Okay. Why?
So I want to also check coronal images as well.
See here, could you detect anything here to confirm lymphangioma?
There's due to high signal areas are there, and there's multiple substation as well, and multi-separated area.
Yes, and what
Yes,
else?
sir. It's causing some pressure or some. What is the electrical language seems to be fine.
Raise your voice,
And
please, doctor. Doctor, please raise your voice.
yes,
There
sir.
are
Sir, I'm
something
just
here. Here. There are something here.
so there is a hypointense ring around this abnormal signal area.
Okay, don't worry about it. Let's see next case. 55-year-old female patient complain of bilateral parotid swelling and dry mouth.
So these are the axial images of the neck.
Yes.
280 images. I said I can appreciate there are multiple tiny cystic spaces seen entirely involving both parotid glands. Parotid glands for normal, they are in size are normal, but they are all replaced or all multiple generalized tiny cystic swellings are there in entire both glands. There's no effect inflammatory changes in T2. I just want to check other images as well. Other than this parotid gland involvement, I also want to check lacrimal gland as well. I want to see orbital search.
What you said? What you want, please?
I want to check lacrimal gland as well. I want to check at the orbit level as well.
This is only, I think here we
Okay.
can check. It is
Okay.
only head and neck. What's your
Okay.
differential diagnosis? This is the lacrimal gland. Here only you can detect the right one.
This seems to be fine. So my first differential, including bilateral cystic area involvement. The Sjogren syndrome can be there, or so Warthin tumors be there. They have multiple
Okay.
cystic. And
What's your differential diagnosis?
there'll be sarcoidosis and also there is this, but Sjogren syndrome, I will it's my first.
Okay, Sjogren syndrome. What is your other differential?
Other would be Warthin syndrome in some lymphoma as well.
What
They have
else?
some
What
viral
else?
parotitis, Warthin tumors, and
What else?
what is,
Time is over.
Thank you so much. Thank you, doctor, so much. Before commenting on this, I wanted to correct something wrong. Fibrous dysplasia is ground glass in appearance because it is fibrous matrix. Okay? Bony matrix gives like osteosarcoma or whatever, give clouds of calcification. But in fibrous tumor like or fibrous abnormality, the fibrous matrix give us the appearance of ground glass. Sorry, but recorrection is a must. Let's revise our cases. This is one of the most important case. Why? Because not the case is difficult, but because most of us are not interested, even I'm talking about myself, are not interested in neck, especially salivary gland, because sometimes it is looks like audit for us. This is bilateral, multiple, almost a tiny cyst, and it almost looks like symmetrical, involving the whole parotids. Let's have a look at the submandibular. This is most important. Why? Why? Because the differential diagnosis either Sjogren or either it's related parotid cystis or lymphoepithelial lesions. What is the differential point, critical point? This, my colleagues, this, if you tell the examiner like this from the beginning, doctor, bilateral, normality imposed parotid, I will check submandibular, خلاص, he will receive that you are differentiated between Sjogren and Israel. Oh, doctor, I can detect even few bilateral cystic lesion in post submandibular gland. So my differential diagnosis would be Sjogren. Thank you that you mentioned. I wanted to see the lacrimal gland. This is very fantastic. So this is a case of Sjogren disease. Sjogren disease is giving the appearance of honeycombing. Also, I'm waiting from you to tell me, doctor, this is honeycombing appearance of post-parotid. This is very good buzzword to be mentioned, but really very good. You picked up well. Another differential diagnosis between AIDS-related and Sjogren, the lymph node. Oh, doctor, but there are lymph node here. Okay, this is inflammatory. This is not the related, or this is not the pathological huge lymph nodes. Okay, my colleagues, why I am stressing on this case? Because I'm stressing in weak points that most of the radiologists didn't liked it, and most of the examiner know that, and they bring it in the exam. Thank you, doctor, so much. This was Sjogren. Oh, first case, fantastic case. Why? This is the first case. I think this very fantastic. You did very well. This is multiloculating cystic lesion in the orbital, right orbital region. This is intraorbital, intraquenal, extraocular. Okay, abutting and surrounding the optic nerve. Tell the examiner that the optic nerve can be detected well, so I can exclude meningioma, glioma. Even this is almost from the beginning. This is lymphatic malformation, but tell the examiner that you are a safe radiologist and you know your differential, how to differentiate from each other. Second point, this is non-enhancing. You did very well. Here, I show you one section. When the examiner show you one section, the answer is within this section. In T2, there are very subtle fluid here. Very subtle, I know. But this is the question of the full mark. Fluid level confirm the diagnosis of orbital lymphatic malformation. Orbital lymphatic malformation. Other malformation like varix, orbital varix. By the way, we should tell the examiner we can do Doppler, especially after Valsalva or during Valsalva. Why? Because it is or if the examiner asks you how to differentiate from varix, oh, doctor, I will do Doppler for the eye and I will ask the patient to do Valsalva. If the lesion increased in size and vascularity, it is a varix. If not, it is not a varix. Other point, there are no flopulus here. No flopulus, no calcification, which is very characteristic mainly of the orbital varix. Thank you, doctor. You did very well. Take these notes for full mark only. Thank you. Next candidate. Are you ready?
Yes, sir. Assalamu alaikum.
Salam. I have great people. We are now 1.5 hours. Most of you are still fighting and struggling with me, and also I will struggle. Yeah, this is candidate 8. Very great, really. We finish a good number. 6-year-old male patient, persistent epilepsy. Take care. This is a tricky case. Yalla, go on.
I've been presented with a CT scan, axial section post-contrast T1 images in which I'm scrolling.
What are you presenting with? Again,
sir,
doctor?
actually sorry, sir. Sir, my
Doctor,
internet
again.
is very unstable here.
I will scroll
I'm not
for
able
you.
to scroll.
Okay, I will scroll. Leave
Yes,
the
sir.
mouse. Start again, please.
Yes, sir. Sir, in the parasagittal area top, I can see certain.
What is the name of this examination again?
Sir, CT scan. Sorry, MRI T1 post-contrast.
Okay.
So sorry. The MRI axial T1 post-contrast images.
Yes.
In which I can appreciate.
Leave the mouse for me. So,
Research, there are certain hypotense areas, cortical areas of hypodensities, which are noted in the bilateral parasagittal regions, as well as along in the frontoparietal and the occipital regions.
Don't worry.
They are
Don't worry about
centered
it. What is this?
on the cortex.
What is this? Look here. Hello?
Yes, sir.
Look,
So these
look
are
here. Look here. The patient has epilepsy. You have some echo. Look here. What is the name of this sequence, please?
So this is coronal T2 FRCR.
Okay. Look here. What happened here? Young, 8-year-old have a persistent epilepsy.
Yeah. Sir, there is a bilateral altered signal seen in the thalami, extending down into the superior cerebellar peduncle.
Doctor, you have some echo in your voice.
I do have, actually, my internet is not very stable, and when you are scrolling, I'm not able to follow you as well.
No problem.
There is
Look
some
here,
problem.
please. Look here, please.
Yes, sir.
And
There is
compare with
a high signal,
with it.
bilateral symmetrical high signal in the brainstem, extending down into the.
What happened here? Comparing to here, patient has persistent epilepsy. What are you thinking about?
Sir, in bilateral hippocampus, more so on the right side.
What? Again, please.
In the mesial temporal region, there is subtle high signal.
What is the name? Okay, excellent. What is the name?
Mesial temporal sclerosis, sir.
Excellent. Right or left?
More so on the right.
Okay, more than excellent. This is very difficult, tricky case. Why? Because our session is in and neck, and I surprised you with a case of brain. And this is a classic scenario of the exam. 40-year-old female patient with left proptosis.
Sir, I am, sir. Sir, there is a axial T2 images in which I can see a well-defined cystic, most probably cystic lesion in the intracornal extraorbital region. That is just abutting the optic nerve. I can see the donut sign of the optic nerve as well in the coronal. It is a high signal on the T2, so most probably it's a cystic lesion.
Which sequence you want?
And
which
I want
sequence?
Post-contrast.
This is a post-contrast. Give me differential
And the
diagnosis.
post-contrast, sir, it shows a subtle enhancement in a part, while rest of it appears cystic, non-enhancing, and it is causing orbital expansions. It can be, sir, astrocytoma or less likely meningioma.
What else? What else?
So it can be.
What else?
So it can be varix as well.
Okay, what else?
But less like. And
yes, what else?
Looks like a benign lesion, sir.
Okay, benign. Excellent. What else? Do we have time or finish?
Sir, 8 seconds left.
Hello?
8 seconds left.
Okay, thank you, Doctor, so much. You did very well. Take some notes. At least if we didn't know the exact diagnosis, we should at least delineate well our description. Why? Here, we can't 100% judge about the relation of the lesion and the optic nerve. Second, don't, please, my colleagues, don't confine yourself from the beginning in one diagnosis. From the start, you told me this is a cystic lesion. Look here, it looks like not a cystic, maybe solid. We don't know. But you can tell me, doctor, this is a bright lesion. After you revised all or most of the sequences, tell the examiner this is cystic solid. Okay, my colleagues. Second point, you told me that you saw a donut sign. This is not donut sign at all. This is outside the optic nerve, completely. Second point, so this is not a meningioma, by the way. Second point, see, the optic nerve itself is not thickened. Okay, so this is not astrocytoma or whatever. So we are dealing with something intraquenal, extraocular, sure, but not originated from the optic nerve. Second point, it show a mural enhancement, cystic lesion with some enhancement or mural enhancement. Revise again the age of patient. Oh, it is not a young patient. But what is the commonest tumor? Benign angiomas. In young age, it is capillary. In elder age, it is a cavernous. Like this, we can think during the exam. Okay. Sure, it is result in proptosis and result in compression or whatever displacement of the optic nerve. This is very good, but at least you should put yourself in the correct pathway. You did very well, doctor. This is just a few notes. This case is very tricky. Why? We are in a hidden neck session, okay? And I bring, this is completely brain case, and very subtle, normal, nearly normal axial post-contrast, and even sagittal. But you have a very characteristic history. 6 years old and has pharmacoresistance epilepsy. You should keep in mind after reading this history, this is mesial temporal sclerosis until proof otherwise. Even, see, this is really, this is not a typical, just there are some signal abnormality here, okay, in comparison to this mesial temporal lobe here. But according to the history and the patient age, you didn't have any other signs to talk about. So your diagnosis must be, doctor, this is looks like, or this is mostly a right mesial temporal sclerosis. Honestly, other signs of mesial temporal sclerosis is not obvious here, like the size here should be less than here. And subsequently, the temporal horn should be larger than here. The interdigitation should be here is less than here. But frankly speaking, this is a subtle case, a tricky case. Thank you, doctor, that you pick up the finding well. You did very well. Next candidate.